So I thank you for the opportunity to talk about what we do, and so this is a good moment to so we can present to you, how's the routine of how we select patients for this powerful therapy that's deep brain stimulation in Parkinson's disease. And the idea here is to cover most of the very basic aspects of what it is, what this therapy is. And I have my colleagues Hafsa and Dr. Afonso Fazano here, who will be uh, um, ready to just confirm or complete or complement my comments here. And so basically what I'll try to cover today is what is deep brain stimulation and how does it work? How does DBS can improve symptoms of Parkinson's disease? Which symptoms can be improved? Which symptoms cannot be improved by DBS? So what is the good, who is a good patient to undergo this therapy? Basically, we need to basically see which patient has those features that are likely to respond to therapy and do not have those that are not likely to respond in general. How do we assess? How do we make this assessment to determine eligibility for Parkinson's disease? Then what are so just a few very generic comments on what are the practical limitations that patients need to consider after DBS, and some of the myths and misunderstandings about the brain stimulation. So deep brain stimulation is one of the therapies that we call advanced therapies for Parkinson's disease. This doesn't necessarily mean that this is a therapy that we only use in advanced cases, advanced disease in general, right? You see from in my next slides that actually there is a very, very limited window in the disease progression in which this therapy is advantageous. And so it's not necessarily advanced disease. We use advanced therapies because it is a sophisticated therapy. It's not first line therapy, but it is a sophisticated therapy. It is a procedure that has been introduced for quite some time now. So it was initially used to treat tremor back in the previous century, basically in 1987. And it started to be clinically used in Parkinson's disease in the 90s. Most of the 90s were the pioneers in this process, started using the brain stimulation. And the Toronto Western team at that time, led by Dr. Andrea Lozano and Anthony Lang, they were among the pioneers in this to use this therapy in the world, among the first few people to use it. So what is deep brain stimulation? So deep brain stimulation consists of inserting in the brain electrodes. So these electrodes will be placed in very specific parts of the brain that we learned from experiments in the past that can be that if you stimulate those areas, you can have improvement in certain symptoms of Parkinson's disease. So the electricity is generated by a pacemaker-like device that is implanted under the skin on the chest. And the electricity travels through the brain through a wire that goes under the skin also, and at the back of the neck usually, and then penetrates the brain. In this video, you see in the brain, what this electricity does is to create a very small electric field in a very specific part of the brain. So in this video, the example is this area called the STN, but there are other areas of the brain that we can use to implant the electrodes and produce this same or similar effect. So electricity is capable, in this case, of modulating brain cell activities and in the end, improving certain symptoms of the disease. And actually, it's not used only for Parkinson's disease. It is used for tremor. It is used for other causes, not in the context of Parkinson's disease. It is used to treat dystonia. Some of you may know what dystonia is. So it's a muscle contracture. It is used to treat Tourette syndrome, pain, epilepsy, even behavioral issues. And this has been, the applications of this type of therapy in medicine in general is growing. And there's lots of research trying to apply to observe the same success we have with these diseases in other new indications. So in the case of Parkinson's disease, the DBS needs to be indicated and performed during a relatively narrow therapeutic window, as I mentioned earlier. So usually we don't indicate the surgery too early, because for several reasons. First is that most patients actually don't need this therapy throughout their disease course, but some do, a significant number do. Others, we need also to be sure about the diagnosis. Sometimes it takes a few years to have the best certainty about the correct diagnosis, if this is something, if it is really Parkinson's disease in this case or something else, right? And also the indication for this period, it should not be too late, right? So we need to offer this therapy to patients who are very likely to respond to therapy first, and also to patients whose main source of disability is Parkinson's disease, and also in the context of Parkinson's disease, patients with symptoms that are likely to improve. If patients' main source of disability in Parkinson's disease are other things that are not likely to improve with this therapy, surgery is not a good option then. There's also an issue of age, and I'll comment later. I think that's an important aspect to comment, right? So which are the good patients to have this therapy? So patients to have had or have a good initial response to the main therapy that we use to treat Parkinson's disease, which is levodopa. Levodopa has commercial names, like Levocarb, Cinemat, or Prolopa, or Stalivo. So all these medications have levodopa in them. So patients who respond to levodopa, but over time develop complications of chronic use, that includes the dyskinesia. So in the involuntary movements that are triggered by peak dose, usually peak dose of levodopa, right? And also patients who have what we call motor fluctuations. So motor fluctuations is a term that we use to describe the fact that patients take a dose of medication, they improve, but then the medication wears off. So they fluctuate from being off and on throughout the day multiple times, right? And that over time can become quite difficult to manage. So we also need to think of patients who will be able to enjoy the benefits of this powerful therapy, right? So they need to have good cognition because they need to appreciate the benefits. They need to be in good general health. So the surgery itself, there is a burden, let's say, of a surgical procedure that patients need to be able to stand. They need to be motivated, so that requires participation of the patient, very active participation of the patient, but also participation of caregivers, family. So the patient needs a good, what we call psychosocial environment that can reassure us that the patient will have support and will need the help that is needed for this therapy, right? So this is the number of procedures, the number of these types of surgeries around the world is growing, year after year. But still, there are more patients that could benefit from this who do not have access to this therapy. For instance, in the US, less than 5% of patients with PD eventually get DBS, and we know that there is a larger proportion of patients who eventually need this therapy throughout their disease course. So it is still something that patients don't take all the advantage of. So, and this is a graph that shows how this is a this is a 10-year-old study that showing that the indications in the number of patients with movement disorders who get DBS is increasing year after year, in one of the leading indications in terms of number of procedures per year is Parkinson's disease. So it is definitely the main indication for DBS in the realm of movement disorders, right? So how do we select patients? So usually we require that patients have a good response to levodopa, as I said in the beginning. So they are usually patients with more than 4 years into the disease. That is necessary for the patients to develop the indications, but also important to define, to be sure that what we are looking at is indeed Parkinson's disease, right? Age is a let's say is a moving target in a few ways, because it is there's no rigid age that could contraindicate the surgery, but the general understanding is that patients who are older than 70 may not have the same good response that patients who are younger than 70 after this procedure. Of course, there are many exceptions to this rule. For instance, there are patients who are younger, but still they're not in good shape. They have problems that may not respond to therapy. Or on the other hand, we have the opposite side of the spectrum, patients who are in their early 70s, but are still very healthy, very active. If it wasn't for certain features of Parkinson's disease, they would still be very functional. So these are, we always keep that in mind when we discuss surgery as a variable here, right? Also, it's very important to remember that the improvement that we expect in the mobility aspects of Parkinson's disease is not for all problems, right? So the symptoms or the signs of the disease that are very likely to improve include tremor, stiffness or rigidity, and slow movements. So these three, which are some of the three of the cardinal signs of Parkinson's disease, can improve with this therapy. Um, and one of the another advantage is that medication can do that as well, but medication has complications. One of them being the fact that it fluctuates throughout the day, right? You need to take a medication to feel its effect. And with this DBS is a continuous 24/7 effect on these symptoms, right? So in this case, just an example. So patients, would be represent the effect of the medication. So your patient is off medication here, improves in terms of mobility, but then the medication wears off, and then the patient needs to take another dose. So patients fluctuate throughout the day. There is also the issue of dyskinesia. So after a certain uh, blood level is reached with levodopa, patients develop dyskinesia. And what happens with surgery is that with stimulation with DBS, the off period would not be as bad as it was before, meaning that when a patient takes a medication on top of the stimulation after DBS, the fluctuations would not be the amplitude of the fluctuations will not be as wide. And the effect of the medication in general will be good, but more subtle. So a patient will not feel the medication necessarily kicking in and wearing off as much as they felt prior to surgery, right? So with regards to other problems that may improve with DBS, one of them are levodopa-induced dyskinesias. So the dyskinesias induced by levodopa may not be as bad because first, the DBS may block the dyskinesias, or they may allow us to reduce the amount of medication and therefore minimizing these dyskinesias, right? DBS can also change the drug regimen, as already mentioned. It can allow us to reduce the total daily doses of medications. It can simplify the drug regimen, and it can allow for flexibility. Either sometimes allowing us to use certain medications that we could not use before at higher dosages because we could not do it, for instance, because of dyskinesia, right? And what are the residual symptoms after surgery? What are the symptoms that we may uh, still be left with uh, despite the good improvement in tremor, rigidity, and slow movements? So balance and gait problems are symptoms that may or may not improve with this surgery, right? So we may not see improvement in balance and gait. Some patients improve, some patients don't change. Some people, so in occasional patients can get worse actually, because we need to change medications, for instance. Facial expression, it can change, but usually it doesn't. It doesn't change much. And also speech. So speech is one concern. So speech can actually get worse, and it's not uncommon to see that. Speech can get worse after surgery, can get more, even more soft and more slurred after surgery. Swallowing can usually doesn't change, for the best for the worst, but we don't should expect to see any change, right? So yeah, so interestingly, cognition or the mental abilities, for instance, uh, they usually, if they are good to begin with, they don't change. But for people who are, in the on, evolving negatively in terms of cognition, not demented patients, but who are declining in terms of cognition towards dementia, should not have this surgery, because the surgery can have a very negative impact on on cognition if patients are susceptible, right? Again, for patients who have good cognition, good memory, uh, good behavior in general, and they are safe to have the surgery. Sleep, interestingly, can improve, probably because of improved mobility throughout the night, so patients can find a more comfortable position to sleep, to adjust their blankets, adjust their pillows, and so on, so can have a better uh, sleep in general. And this is quite consistent. We see patients saying that their sleep improved after surgery, right? So this therapy is a complex therapy, as I mentioned. It's a powerful therapy, but it is also very complex. It requires multiple steps in terms of assessment and to determine eligibility for surgery. It requires the involvement of different fields, right? So neurology, neuropsychology that assess cognition, neuropsychiatry that assess behavior in Parkinson's disease. Obviously, the surgeon and but in most cases after surgery, patients are in our hands, the neurologists, the clinicians. So we are the ones who take care of of patients who have had this surgery. um, and even if patients come from other neurologists, they usually tend to, they need to see us, who, because we are, the center of reference in here in this province, at least, for to see these patients, to do programming, to assess battery life, and to refine the treatment in general, right? So usually the patients flow from the first referral to us to surgery is something like this. So patients are referred to us. They come for their first visit with us, in which we determined a very general indication for surgery. The first is basically our first encounter with the patients. Then we do what we call the 2-day assessment. Basically, that involves 2 days. Before COVID, it was done in 2 consecutive days. We try to go back to that scheme after, hopefully, when COVID calms down. But in these 2 days, what we do are assessments for memory, a neuropsychological assessment, very deep and thorough assessment of memory. We do a Levodopa challenge, that's a test in which we measure the amount of response that patients get from Levodopa. And also we do, the patients they have a consult with our psychiatrist. And our psychiatrist will basically assess how is mood, behavior, and if there's any concerning aspects from this point of view, right? Then surgery, right? The surgery, before surgery, the patient will meet with a neurosurgeon to describe, to confirm eligibility, to make sure that there's nothing from a technical point of view of surgery that they need to be looked at. And then after the surgery, the patients are back with us, the clinicians, and we do the programming of the brain stimulation, which is a very complex and sophisticated procedure. And follow up, again, we do the fine tuning of trying to improve symptoms that are residual, of symptoms that arise with disease progression. We adjust medication and so on, right? So the process in terms of time is long. We need to keep that in mind. So from referral to first visit, somewhere between 3 to 6 months, I would say 4 months in general. From the assessments to surgery is in the range of it's longer than that. It's probably 4 to 6 months, another 4 to 6 months. And then the programming, in the other steps that take at least another month and a half. So we're looking usually from the referral to be being optimized. We're looking at definitely more than 1 year. So we need to keep that in mind and be conscious about, the waiting list and the time it takes for things to be done in a system like ours. But still, it's a very well planned, a very oiled system in many ways, right? So this is just another overview of this sequence. So referral, usually the first consult and then the assessments. We also have a multidisciplinary meeting in the middle, in which we meet with the whole team meets, basically the nurses, the psychiatrists, the neuropsychologist, the surgeon, ourselves. We discuss every single patient that will have had surgery within the next few months to determine if there's any particularity that needs to be addressed. So how is our center in the middle of many centers in the world that perform this procedure? So the Toronto Western is one of the top 5 centers in the world, one of the 2 or 3 in North America in terms of volume. It was one of the first to perform the brain stimulations in the Americas with many years of experience. The program here, as Dr. Fasano mentioned when we were prior to the talk, is one of we do most of the cases of this procedure in Canada, right? And we have we are reference. We are in Canada. When people think of deep brain stimulation, if they want to think of one hospital, one center that does this, usually the Toronto Western that comes to mind. With the increasing needs and demands over the past few years, so me and Dr. Fasano, we've been the directors of this unit for the past 8 years now. And over this year, we reformulated the way things were done before. We expanded our unit. We have more staff. We have a very, as I mentioned, very well-oiled flow of assessments that are needed to determine eligibility and to take care of these patients. The physical structure of the movement disorders clinic has been expanded as well. We have many trainees and observers from all over the world that come to train and learn how we do things here and try to apply that to their own country, their own service. And also, we have a very prolific scientific production. Dr. Fasano is one of the main researchers in this field in the world nowadays. And basically, lots of the information we know about the brain stimulation can be traced at some point to Toronto Western during or prior to me and Dr. Fasano's era in this unit. How does the DBS change patients' routine? So physical activities, we definitely need to be mindful of possible trauma or damage to the hardware, right? So patients often ask what type of physical activities they can perform. Basically, it's any activity that could have physical impact on the battery, on the wires, on the top of the head where the electrodes is implanted. So just think about it. So for instance, hockey, soccer, jiu-jitsu. There's a patient the other day asked me about skydiving on after DBS. Not a good idea, probably. Then other things practical. So sauna, hot tub. So we're very often asked about, can I continue to do this? Often what we recommend is that the patient is not immersed or is not in an environment in which the temperature is higher than their own body temperature, right? So we say 39, 38 degrees Celsius, right? Traveling security, in airport securities, again, there's no issues usually. So of course, the most of the parts that are implanted are metal. So the metal detectors will detect it. So usually patients carry a card that describes the device, the manufacturer, what device is implanted, and that's traceable to the patient. So the airport personnel can make sure that that patient has that device, and they usually scan it. So there's no danger. It's important to keep that in mind. So the metal detectors will not cause damage to the hardware or the programming. Diagnostic tests in general. So the tests that are concerning usually ECG, electrocardiogram. Again, it will not damage, ECG will not damage or cause harm to the device or the patient, but the electricity from the device can interfere with the reading of the ECG. So it may basically waste the reading, right? So it's important to switch off the DBS. Just what's done to avoid is just switching off the DBS, basically, right? And then the MRI is another story. So MRI, so it creates a very strong magnetic field that can move the parts of the DBS, the brain stimulation, so it can hit the device as well. So in theory. In practice, we're learning more and more that with the newer device in particular, it is safe. There are precautions that need to be taken. So this is probably the test that needs more care in general, more attention. And usually we have specific recommendations to do an MRI. So it's not contraindicated, but there are specific aspects that need to be looked at, right? The other tests are usually safe. So CT scan, ultrasound, X-ray, they're not risky in any way, right? Surgeries, there are things that need to be considered. For instance, any surgery that needs cautery to stop bleeding, right? There are specific recommendations that need to be looked at. But again, it's not contraindicated, but there are specific technical changes that need to be made to the device, to the cautery, to avoid any issues. And again, another practical issue is battery life, right? So battery life, the standard batteries that is implanted on the chest, the device on the chest, needs to be replaced every few years. There are now rechargeable batteries that allow patients to remain with the same battery for 15 to 20 something years. But the old or the standard batteries they're not rechargeable, they need to be replaced every, let's say, 3 to 5 years, depending on the amount of energy being used, obviously, right? Patients who demand high energy to control their symptoms will need more frequent battery replacements, obviously. And again, just to finalize some of the myths and misunderstandings. So DBS is not a cure, right? We're not, unfortunately, this is not still the answer to a cure in terms of a cure for Parkinson's disease. On the other hand, it's not something experimental. It's not something, it's not sci-fi, something that is used routinely in practice in neurology for several years, for more than a couple decades already. So it is something, a routine. It is a routine, right? DBS does not alter, not interfere with brain dopamine. So this stimulation is not something to stimulate dopamine. Your brain will not produce more dopamine under DBS, right? It's important to keep in mind. This is an electrical stimulation that will change the negative effect of lack of dopamine, some of these negative effects, right? It's important also to know that DBS is not a replacement for medication, right? It can allow us to reduce medication, but not stopping altogether. Patients in which DBS can replace medication completely are very unusual, very rare, right? This is not a replacement for medication. Those patients who have had surgery, they remain on medication still, less or a different regimen, but stay on medication. Not everyone is a good candidate. Actually, it's a minority. It's a significant minority of patients. It is a significant number of patients, but it's not a majority of patients, right? And finally, the benefits of DBS do not expire. So patients frequently ask, how long will my device or the benefits be observed? For how long I'll have the same benefit? So the way I say, I tell patients is that the good effect of that you will see after the surgery will remain relatively well controlled throughout your life, but over time, new features of Parkinson's as a progressive neurodegenerative disease will be added to the equation and may or may not be addressed by DBS or by medication, right? So the good effect of DBS, for instance, the effect on tremor, the effect on rigidity, will remain there for several years, right? And this is my last slide. You know what? I already over time, so I won't. I'm not sure if the videos will really add anything, but this is my last slide. I just want to move to and thank my whole team for the work with us. They definitely every one of these people in this list is essential to make our team what it is, and we rely on them every day, all of them. and again, thank you for inviting me.
Yeah,
If you
thank you.
have questions, I think with our whole Dr. Fasano and Hafsa are here to try to answer it for you. Thank you.
Okay, thank you very much. Yes, does anyone have any questions that they'd like to ask the team?
Yes. I do, Elaine.
Okay, go for it, Elaine.
Well, you mentioned ideally it's better done if you're under 70. I'm just wondering what the referral period is like if you're 68. Is there any chance you're even going to make it to the clinic for assessment? Did you hear my question?
Yeah. Renato, maybe you want me to take the question?
Yeah, you can take this.
Yeah, so simply put, age is a number. So we don't just look at the age of the person. There are good 75 and there are bad 65. There's the age of 70 is just to give you an idea more or less of when things get a little more risky. But we have done DBS also in people over the age of 70 with no problem. We also refused people that were sent to us simply because, oh, next year I'm going to be 70, so can you do something for me? But they weren't severe enough, so there is no point in doing surgery when they don't need it. There are also other options for people that are in their 70s or even their 80s. There are different targets for deep brain stimulation. There are other advanced therapies that can be done. So age should not mean that people have to be rushed to the clinic. We assess them when it's needed and we take the next step accordingly. So It's not a hard cutoff. That's all I want to say.
And is there quite a backlog now because of COVID restrictions?
Yes and no, because thankfully we've been, as Dr. Munitz mentioned, we have a lot of support from fellows and also nurses, nurse practitioners, half size with us today, for instance, and she can tell you. So we've been able to see many patients also with telemedicine. So we tried to do as much as we could, even when we were in complete lockdown, seeing patients remotely, so through the computer, because we didn't want to make the waiting list even longer. And I guess we did a good job. And also the hospital helped us, because at some point we could not do any elective surgery. But then the hospital, when we opened, said, okay, you have more OR time. So instead of going back to 100%, we went to under 5%, for instance. So we could catch up. And also some patients probably that weren't doing too bad on medications only, they refused surgery. They were too afraid to come to the hospital. And the paradox of that is that a lot of other people got surgery in the meantime. And the waiting time actually got shorter at some point. So yes, COVID is certainly making things more complex, but not necessarily the waiting time.
Oh, good. That's good to know. Thank you.
Okay, thank you. Any other questions? Anybody has? Okay. All right. Well, thank you so much to all three of you for such a wonderful presentation. And I definitely learned a lot today. So thank you very much. I really appreciate you taking the time to speak to our group and sharing your knowledge and information on deep brain stimulation. It's fascinating. And it's definitely a way to improve quality of life for individuals with Parkinson's disease. So thank you so much.
Yes, thank you.
Our pleasure. Thank you.